Good afternoon, everyone, and welcome to this fireside chat with the title of What Does the Pandemic Tell Us About Future AI and Digital Approaches to Healthcare? My name is Piers Ricketts. I'm Chief Executive of Eastern Academic Health Science Network. I'm also chair of the National AHSN Network. We are the innovation arm of the NHS. So what we do, we have 15 organisations, 600 or 700 companies that look to support our health and care system with the adoption of late-stage innovation. I'm joined by two colleagues, Keith and James, whom I'll ask to introduce themselves to us now. So Keith, do you want to go first?
Yeah, sure. Thank you very much. And hello, everyone. My name is Keith Grimes. I am the Clinical Digital Health and Innovation Director at Babylon Health. My background is as an NHS GP, having worked as a GP since 2000 with a special interest in urgent care, but a real passion for innovation and technology, which I've taken forward in my work with Babylon for the last 2.5 years. And for those that don't know Babylon already, Babylon has a mission of providing accessible and affordable healthcare, or putting an accessible and affordable health system in the hands of everyone on Earth. And part of that is by providing telehealth services, things like video consultations, increasingly an integrated service, and also self-care products that are powered by digital health and artificial intelligence. So hopefully I'll be able to share some of our insights during the talk today.
Thank you, Keith. James?
Thanks, Piers. Good afternoon, everybody. My name is James Duez. I'm the Chief Executive and co-founder of Rainbird. Rainbird is a decision automation platform. So it's all about taking human expertise and embedding that in software in a very innovative way to enable us to build systems that can automate the kind of complex decision making that traditionally has been reserved for humans as a very new capability. My background, actually originally a software engineer, but in recovery now for some years. I spend most of my time working in the AI space over the last 15 years, trying to scale these new capabilities to these new sorts of use cases. And healthcare for us has actually been something that over the last 12 months has become increasingly in focus, obviously with COVID.
So thank you very much, James. That's fantastic. So the two of you like to have equally relevant, but some complementary perspectives, I think, on what we're going to be talking about. So I'm conscious we've only got a relatively short amount of time, but I think we should probably start by testing ourselves some definitions. So actually, I'm going to ask James, what do we mean by AI in this context, future AI and digital-based approaches to healthcare? Can you set out some definitions for us, James?
Yeah, so sure. So I think the simplest AI is a computer doing something that we thought was intrinsically human. So, but AI as itself, I would put forward is a singularly unhelpful term. It describes a very broad church of technologies. A lot of people, when they talking about AI, they're really talking about machine learning. And I think it's important probably just to clarify that machine learning is certainly AI, but not all AI is machine learning. AI is a overall term for a whole range of technologies that can typically are about trying to find insights in data that are opaque to us, by other means, but also it's very much about automation. So typically, if you want to sort of separate it into a very simple way, we might describe some AI solutions are kind of data up. They're building algorithms based on historic data. And that's really where the machine learning camp is, along with all of its different variants, deep learning and so on. But there's also a whole classification of AI, which is human down, which is about taking human models of expertise and using that to scale in systems to automate what traditionally we do.
Thank you. That's very clear. Keith, do you want to add a sort of more either healthcare-centric or Babylon-centric take on that?
No, it's beautifully described. And actually, to extend it, if you say, well, what is AI in healthcare? And you say, well, that's computer technologies that would do things that would traditionally required a healthcare professional to do. So you can nicely extend that as well. And when I describe AI to people have a lot of ideas in their mind, but I can't try and keep it simple and think, well, humans do a lot of different things. Our brains do a lot of different things, and equally AI can describe all the different processes, all the different tools that are gathered together in sort of one human function, but we can use them individually. So we have tools for helping with calculations and decisions and so on. So thinking of AI as a sort of toolkit of techniques to deal with some of the things that would ordinarily require a healthcare professional to do is a great start. Of course, when AI gets very exciting is when it starts doing things that healthcare professionals couldn't possibly do. That's the bit that gets interesting.
Yeah, and probably makes some people feel a little bit apprehensive, I suspect, but we might get into that. So should we sort of move on to the effects of the pandemic? And James, you're the chief exec of, I suppose, a sector agnostic business in some ways. You work across a variety of different sectors. Do you think the pandemic has accelerated the use of AI-enabled technologies?
I think it certainly has. I mean, just to put that in context, in the last 6 months of last year, we did more projects than we had in the previous 2 years. And that was so certainly I would say has accelerated. But again, I think it's a lot of the focus of the work that we've been doing is really with an automation use case. And that's the pandemic has created this new impetus to be able to sort of have to go out there and solve problems at tremendous scale. So I mean, an example of that would be within healthcare, the need to go and risk assess all million plus NHS frontline workers in England to ensure that the NHS have a very thorough understanding of the health risk to each individual. Now that's a problem of scale, which is not something that you can just, you know, snap your fingers at amongst the most stressful time for the NHS and go and do without the use of technology. So I think, you know, organizations have been aspiring to become more digital. I mean, the automation phenomenon is an unstoppable train that's been going for many, many years. And I think a lot of those organizations, not just within healthcare, but, you know, we work within financial services, in tax, lots of areas, they've aspired to be more digital. And I think actually what COVID has done is it's now made that a necessity. So it's gone from being a desire and an aspiration to being a matter of survival. And I think when we've gone to particularly having distributed workforces where there's a lack of physical supervision, you then start to think about, well, how can AI and these technologies start to make decisions to ensure not just efficiency amongst sectors where there's financial pressure, but actually to be able to create much better quality outcomes, whether that's for patients or for customers, and actually to try and innovate and create entirely new classifications of product and service that just would not be possible without these technologies, but where the pandemic has provided that need to pivot and change a business model. So it's had a profound effect, I would say.
Yeah. And of course, we've seen throughout the sort of mainstream NHS, the massive shift of primary care to a combination of telephone, video and online technologies, many outpatient appointments also done digitally, diagnostics coming not just closer to the patient, but sometimes into the patient's home. So Keith, Babylon was obviously one of the pioneers of digital and online primary care consultations. What increase in uptake or shifts have you seen over the last year?
Yeah, it is true that Babylon has been working in this particular area with a digital first approach to primary care and then increasingly a digital first approach to integrated care, even prior to the pandemic. And what's interesting is the pandemic really showed that people pre-pandemic, one of the great statistics was in November 2019, about 3% of general practices in England used video consultations. And by July 2020, that had risen to over 99%. So that's an extremely short period of time deploying that. But that, of course, is technically not really artificial intelligence. This is the use about telehealth as well. So we saw great changes in that particular area, and some of those changes are here to stay. Now, what comes off the back of that is an awful lot of data, and at the same time, there was a lot of resistance to access to data pre-COVID that went away very rapidly because needs must. And what that means is that we've now got more data coming in. We're collecting more data as a side stream of telehealth, and we've actually got freer use of data entirely appropriately, but some of the barriers have gone away. So what we're now seeing is we're seeing the consequences of that, which is good. And that's going to bode well for this middle part of the pandemic and as we come out of the pandemic. I think importantly, artificial intelligence and the technologies of artificial intelligence, for us, it was mostly about being able to we still had a great need across the healthcare service to have healthcare professionals provide essential services. So automation, just as has been said here before, it's about automating those things that can safely and with quality be automated. So in our case, it was about developing our symptom checker to be able to help people understand whether they may have COVID or not and what to do. Now, that has been a challenge, particularly at the start, when AI obviously requires on large amounts of high quality data. And it's fair to say that there were not large amounts of high quality data at the start of the pandemic, but that is changing now. So it's been a very interesting year in using different approaches to artificial intelligence, more expert systems towards the start, and then more deep learning approaches later on. I think that's been the lesson of artificial intelligence for us over the course of the year.
And if I could just chip in on that, actually, sure. I think what's really interesting about that is those two approaches. So, Rainbird's approach is when you don't have a lot of data, you can take the very latest expertise that you have, and you can very rapidly build models that scale that. So the idea of using Rainbird for risk assessing frontline workers was a discussion, and eight days later, this was live in 3 trusts. Now that's something that you can't do with a machine learning approach. It takes much longer. It takes lots of time, money, faith, and of course, huge amounts of data to be able to achieve that. I think what's interesting and where the future is going with this is actually this human down approach of, as Keith describes, a sort of almost expert system tech, and the data up approach are beginning to meet in the middle. And this has actually been Rainbird's long-term research interest for a while, which is how do we get the best of, start from a corpus of human understanding on a subject rather than starting from scratch. And how do we then integrate what we can learn from data, but critically bring explainability and transparency to those decisions? Because ultimately we only trust technology that we can understand. But I think it is the hybrid of those 2 approaches together that I think is the future.
Yeah, and when we were chatting before, we were going to say, well, what do we think the obvious wins are, for AI? But I think you've articulated quite a few of them there. I guess just a follow-up question to Keith, perhaps. You mentioned data. Clearly, you need patient consent for the uses of their data in various different contexts. You said, you didn't have great data on a wholesale basis at the start. It's better now. Have you had to rethink or think further about the kind of consents that you've had to obtain, during this, or the things that you'd set up at the start have served you all right, or have you had any further reflections on the sorts of consents patients need to give?
Yeah, no, absolutely. I think that you constantly want to be revisiting how you're using the data to make sure that you're using the best, the sort of the most current understanding of, the secure use of data, using it ethically and so on. So it's constantly being reviewed. And I think along the course of the year, one of the things that's happened is that, some of our principal focus is about helping patients and using the data to help deliver the clinical services, or meeting the first, the initial clinical needs of a patient. I have a problem, I want to know what I need to do next. So we use the data to help inform that. But along the way, there was a great need from the wider community, the health community, the science community, and the digital health community to contribute towards the research base as well, to have a greater understanding of this evolving problem with COVID as well. So a lot through the year, we had to revisit how we then consent people for the use of their data for the purposes of research, particularly publication research. That would be one area that evolved over the course of the year. And we'll continue to keep an eye on it as well. We also have the option for people to elect to have their data used for the improvement of the product as well. And some users will want that, and some users won't. We have to build our system to bear this in mind and make sure that those people that are happy to have their data used for the clinical service, but not for the improvement of the product specifically, that we develop a system to make sure that remains separate.
Yeah, that's very clear. Thank you. Well, let's stay with you, Keith, just for the next one. Can we start thinking about the long-term impacts of AI technologies on healthcare? There's greater efficiency. There's being able to automate tasks and processes that one wouldn't have been able to do otherwise. Some of these big tasks you spoke about, like the risk assessment that James was referring to. Will it help us to deliver better quality of healthcare? Some of those early attempts at clinical decision support weren't always successful. Will it give us a sort of myth of, or the thing that we've longed for, of more healthcare professionals' time dedicated to frontline care? What do you think the long-term impacts might be?
Yeah, well, it's the Eric Topol, when he came to do his work for the Topol Review here in the NHS, and in his recent book on deep medicine, was talking about freeing up time to care. And that's one of the great aspirations that we have for any kind of automation, be that AI or any other digital health technologies, that we free up time for the healthcare professional and the patient to do that thing that is uniquely human, the thing that humans are best at, communicating, coming to shared understandings, and making shared decisions as well. So yes, it's all about trying to find those things that can safely be automated or deliver, predictable outcomes at scale. And things such as triage, automating triage is definitely one of those areas. We can also use it sort of the less high intelligence ends of artificial intelligence, like robotic process automation and so on, which is a really fantastic way of actually bridging the gap for interoperability. And that's one of the big things, is that, you know, AI needs an awful lot of good quality categorized data to be able to do its thing, or rather machine learning does. But we have a number of systems that aren't always talking to each other. How you get data between them is a big part of the work that we do. And part of it is actually using these robotic processes to simulate what humans do to transfer the data across. And I think that's a really important thing to help us assemble these large data sets. And then once we have these large data sets, we're then able to use some of the technologies that we were hearing about before to be able to do things like risk stratify populations at scale, do counterfactual simulation, and understand, you know, causative links. One of the nice things that our research team last year published in Nature Communications was a proposal about establishing causation, which is such an important part of the diagnostic process. And as we look to try and implement this in our products, part of it might be to look at how we can see what is for a certain population, who would benefit from these interventions, you know, making sure that the best outcomes are delivered to the people at the right time. I think that's the hope going forward, particularly when we're dealing with COVID and big catch-ups that we have to do for people with chronic conditions, with cancer and so on. You know, we need to start to really drive efficiencies there.
Yeah, thank you. We need to wrap up sort of fairly soon, but if I sort of go back to James, do you think there are any signals emerging to indicate you know, some caution, or some of this is slowing down? How are you making sense as a business that yeah, runs across a number of different sectors? About, we've heard talk about the new normal. Are we returning to something more of a normality? How do you see the outlook? You know, what are the learnings and the things you think were definitely going to apply from the last 12 months?
Well, so I think in some areas, you know, the cat's kind of out of the bag. I think your distributed workforces are much more working from home. I think there are going to be some societal sort of shifts that are going to stick. I think in terms of caution, you know, some of the biggest challenges around these technologies, and I just want to say, I absolutely agree with Keith. There's an awful lot that is human about AI. AI is absolutely about freeing up people to be able to do the things. There's a big long list of things that technology is very poor at, such as listening, building rapport with customers. And so there's no lack of work for people to be focused on once they've become augmented in their day-to-day jobs by this technology. I think the caution continues to be around the issues which have been talked about quite a bit during the festival, around explainability and interpretability of how these models work. I think it continues to fuel all of the ethical discussions that there are around the use of these technologies, and certainly, you know, we have the privilege of being a platform business that is a horizontal capability that's trying to push this out. We have a machine learning pipeline, we have a sort of human-centric tool, we have tools across all the different AI, I said, the broad church of AI capabilities, but absolutely central to what we're focused on, because I think it is the single most important thing, is explainability. We have a long history as a human species of not trusting technology that we don't understand. And I think this is really what separates what often is you know, analysis methods that still require a fully competent human being on the end of a process to interpret the results, and perhaps some data science work is you know, incredibly powerful at finding those insights that we need to make a more informed human decision. And then there's full automation, where we're taking human expertise and we're building that into the system and front loading it, so that you have a technology that can fully automate a decision without reference to a human. And that's where you can, you know, risk assess 1 million people in one afternoon if you need to, because there isn't a human in the loop. But that can only come when you have absolute clear explainability. And that's not just necessarily understanding how an algorithm works. I think for us, that is about being able to say, right, on this particular case, this patient or this person, this decision was made. This is the entire chain of reasoning as to how that decision was reached, not as its probability, but how any uncertain or missing data influenced that decision. So you end up with an irrefutable audit trail, which is something you don't get from humans, and it's something that you can't generate from just from pure machine learning. So I think, you know, the risks continue to be around the ethical issues and around explainability, and I think that's a very big area for the future. But no, I think the cat's out of the bag around the use of these technologies, and particularly, as I say, you know, putting this into the hands of startups. I mean, we've launched a startup program in the last 6 months, where, you know, organizations that want to try and build new types of products and service can get access to the technology for a fixed fee, because it's about seeding this capability in and enabling people to to grow their businesses using this very new classification of tech. But I think explainability for me continues to be the key.
Thank you. So ethics and explainability. Probably the last word to Keith. Would you agree with that? Or?
Yes, with not much time left, absolutely. I mean, if you're looking at the ethical issues, the ability to make sure that the service is just, that it's available to everyone, and that people can make autonomous decisions about this. Explainability is key. This is why we've chosen certain AI technologies to serve certain purposes as well. If we also want to deal and make sure that the most disadvantaged people, those people that are least represented in data right now, get the service that they rightly expect, we have to approach it this way. We have to make sure that the decisions are explainable and that we do our best to reduce bias in what data is used to train these AIs.
Fantastic. Well, that's been a really, really interesting conversation. Left us with a couple of big questions, I think, that we'll all be monitoring over the next sort of 6, 12, 18 months. James and Keith, thank you both very much. Thank you.
Thank you.